So thank you everyone for joining to Echo Rounds today. So I'm Taylor, one of the C3s if I haven't met anyone here. And today I want to chat about echocardiographic assessment of prosthetic valves. So there's quite a lot to get through. So the main objectives for the talk today will be to review the types of prosthetic valves, review the Doppler assessment of prosthetic valves, the approach to high peak velocities across valves and patient prosthetic mismatch, and then if we have time, review complications in the monitoring guidelines and potentially a few cases. So to start off, I want to start with one case. This is a 25-year-old female who had a history of a mechanical aortic valve replacement with a size 19 valve and a mechanical MVR done about 3 years ago for rheumatic heart disease. And on presentation to hospital, her medications were warfarin. However, she had not been having regular INR checks, so her INR on presentation was 1.2. And she essentially had presented with worsening exertional dyspnea, which was class 3. So if anyone, maybe one of the cardiology residents are on the line, there's just a couple images we can go through for the echo, if anyone wants to take a go at it. Are there any residents on? No. If not, I can just go through this. So
I can do it if you want, Taylor.
Sure, Cody.
Yeah, so it's a parasternal long axis shot. We're seeing an RVOT that looks about the right size, and aorta, which looks similar. The left atrium is shadowed, or there's an acoustic shadowing, both from the struts of what appears to be some form of non-native aortic valve, as well as a mitral valve. Hard to say, but the degree of shadowing could suggest, or shielding artifact could suggest that it's mechanical. I didn't hear, did you say bio MVR or mechanical MVR?
Both were mechanical.
Okay, yeah, so it kind of is consistent both with the kind of artifact of shielding that you see with metals. So there's this kind of long tails, both at the root of the aorta and the mitral valve. Now we're going to the M mode through the aortic valve. You can see there's a bright white line kind of oscillating, which is the anterior strut, and then there's a posterior strut. You don't really see any leaflets, or at least I can't see any leaflets within them. And then similarly, there's an M mode that goes through the mechanical mitral valve, where you get the semblance of an orifice, which is oscillating with the cardiac cycle, but you don't see any leaflets or anything else. Now we have the zoomed in shot, and you can actually see the leaflets of the disc that's in the mechanical valve. Sorry, now it's, and then we're looking for color. So now we're looking in that same area for color flow. I don't see any obvious, sorry, it's frozen there. I don't see any obvious regurgitation. Well, there might be a little bit of regurgitation actually from that aortic valve, probably a little bit of intravalvular AI, but you can't see mitral regurgitation because of the shielding artifacts. You don't really get a sense that there is. That being said, that amount of jet that you see laterally on this aortic valve may in fact be washing jets as well. LVOT diameter 1.9 centimeters, or whatever it's worth. Now we're looking at a parasternal short axis view through the aortic valve, and we're seeing that there probably is a semblance of washing jets there, but no significant amount of paravalvular regurgitation. Now we're looking at a parasternal short axis view slightly lower at the level of the mitral valve. You can actually see the discs opening and closing. I'm assuming the next is color. I was right. And again, you see probably the washing jets from the aortic valve versus a little bit of intravalvular AI. You don't see any paravalvular issues or concerns for possible mitral regurgitation in that view. We've gone a little lower to the level of the pap muscles, where you see that the myocardium appears to be thick actually, but it's contracting. There is some kind of wall motion abnormalities, a little bit due to the posterior mitral valve placement.
Just a few more.
Sure. So apical four-chamber view, we don't see the RV or the RA very well. I'm sorry, it's not, yeah, there you go. And again, we're seeing inflow into the LV cavity. I don't see any concerning signs that are suggestive of significant regurgitation, although again, we are limited by the metal shielding artifact. So we have EA fusion here of the Doppler of the mitral valve inflow. Actually, it's probably AFib now that I look at it, but it could be EA fusion. I'd have to see more. But based on the pressure halftime, the mitral valve area is reportedly 4 centimeters squared. And similarly, there is a mean gradient of 9 millimeters of mercury at a heart rate of 91.
And last couple.
This is a challenging 5-chamber view with Doppler. Looking for the LVOT VTI, or sorry, the LVOT VTI and its profiles. So the V1, let's see here, VTI 13, Vmax 0.71. So it's a little lower than expected, but okay, probably within the normal. And then, oh, hello. That's interesting. So the aortic gradient, mean gradient, is 81 millimeters of mercury, which by all definitions, I'm presuming is abnormal. I don't know what type of valve this is, but I'm sure 80 millimeters of mercury is not what it was built for. And the aortic valve area, which is challenging because you're actually, the continuity equation assumes that there's going to be orifices that are unimpeded. So it's a little bit more challenging to say that the continuity equation holds in this case. That being said, the VTI aortic valve area is quite small at 0.3 centimeters a second.
Perfect. Thanks
now,
so much, Freddie.
Looking back, I would wonder if that AI that I was seeing, that maybe a washing jet might have been a stuck leaflet, but I'm sure you'll get to that.
Yeah, great. So Freddie went through all of this. So the main sort of big things out of this study was, it didn't show you all the images, but preserved LV function or low normal mechanical mitral valve. And the mean gradient was 8 at a heart rate of 92. We couldn't really assess the presence or severity of regurgitation. And there was a mechanical aortic valve. Keep in mind its size was 19 with a quite significantly elevated mean gradient. The EOA came out to 0.3 when you calculated it out, and a low DI. So what I just want everyone to think about, and we'll come back to this case at the end of the presentation, is sort of what is your differential diagnosis for the elevated gradient in this case, and sort of what would you think about for next steps? So with that in mind, the main guidelines for the prosthetic valves are from the 2009 Journal of the American Society of Cardiology, and these essentially gave guidelines on the evaluation of valves with echo. And what these guidelines outlined were essential parameters for evaluating prosthetic valve function, which included clinical information on the valve, the patient, and patient's vitals, imaging of the vitals, imaging of the valve, Doppler assessment of the valve, echo assessment of the chambers, concomitant valvular disease, estimation of pulmonary artery pressures, and then always comparison to prior studies. So I'm going to start off by talking about just evaluating the prosthetic valve type and size. So as we know, there's two different main types of prosthetic valves, which would be bioprosthetic and mechanical. Bioprosthetic being stented, stentless, or percutaneous, which we're seeing a lot more common now with TAVIs. And then mechanical, the most common ones being bileaflet, then there's single tilting disc and caged ball, which we're seeing less commonly now. And this is just some images of those valves. So the bileaflet we're quite in the top left corner, we're quite familiar with, and then the stented valves D and E, and then our percutaneous valves G and H would be our Edwards Sapien and our core valves, which we're using for TAVIs. So when we look at the different prosthetic valves, they have different hemodynamic profiles according to their valve type and size. And with all the valves, there is some degree of dysfunction that is considered within the normal range for a particular prosthesis. And these guidelines have been published for what is considered normal for each of these valves, and we'll come back to those. So the next step based on the guidelines is sort of to think about imaging of the valve. So I think the most important thing is always to compare to a baseline study. And then moving on from there, the evaluation is really pretty similar to native valves, but some of the challenges are that reverberations and shadowings really play a significant role. And then along with that, as I mentioned earlier, fluid dynamics of each of the specific valve prosthesis will really influence the Doppler findings. And some of the other things that you can see are, which we actually saw in the start of this study, were microcavitations, which can be normal, which are microbubbles that can be seen in the LV with mechanical valves, usually due to degassing of carbon dioxide. So when we talk about shadowing, here's an example of the typical shadowing for mitral and aortic prosthetic valves in the parasternal and apical 4-chamber views. And to the right here is an example of what reverberation artifacts can be like. And it's really because of this shielding and artifacts that regurgitant jets can be difficult to view and can require multiple different angulations of the probe or off-axis views, and really for especially mitral valves, TEE for better assessment. So it's recommended when we start with valve inspection that the key things that we need to assess is the opening and closing motion of the moving parts of the valve. So the leaflets for bioprosthetic valves or occluders for mechanical bioprosthesis. And then look for the presence of leaflet calcification, abnormal echo densities attached to the sewing ring, occluders, leaflets, or stentor cage. And then the appearance of the sewing ring itself, regions of separation from the native annulus, and any abnormal rocking motions. So this is just an example of what some of these valves look like on TEE for the mechanical valves. What we can see in this images in the middle, if you look at where the arrows are pointing here, this is pointing towards the occluder mechanisms and what they normally look like for these different valve types on TEE. And then on the images in the right, we can see what typical physiological regurgitation for each of these valves look like. And we can see that the intensity of the regurgitation is different and placement is a little bit different depending on the valve type. Similarly, this is what a TEE normally would look like for our stented and stentless valves, as well as our percutaneous valves. And we can also here see some examples of what paravalvular leaks would look like. So I want to spend most of the time chatting about the Doppler assessment of prosthetic valves for stenosis. And I'm going to start off by chatting about the prosthetic aortic valves, and then we'll move on to mitral valves. So I mentioned earlier that the Journal of American Society of Echocardiography provided normal guidelines on what normal Doppler values for prosthetic aortic and mitral valves should be. And this is just an example. It's a very short excerpt of the very long appendix 1 for each of the different types of valves and normal expected peak mean gradients and EOA for each of the various sizes. And when we look at the Doppler assessment of aortic valves, the key parameters that we want to look at are peak velocity, peak mean gradient, the jet velocity contour, acceleration time, and ejection time, the EOA by continuity equation, dimensionless index, and then look for regurgitation. So starting off with the peak velocity, so normal peak velocity for our prosthetic aortic valves is typically less than 3 meters per second, which is a little higher than what we would think about for native valves, and a mean gradient less than 20. And this is because there is usually a little bit of degree of dysfunction, which is considered normal. And then in terms of abnormal, so more than 3 is suggestive of possible stenosis, and more than 4 meters per second would be significant stenosis. Similarly, a mean gradient more than 35 would be significant. And to get your peak gradients, you can use a simplified Bernoulli equation to assess that. And this is another look at what that would look like on Doppler with our peak velocities here. The next thing that we really look at is the CW jet velocity contour. So typically in normal valves, it's typically triangular shaped, early peaking with a very short acceleration time, versus in the presence of stenosis, the jet contour becomes more rounded, tends to be peaking more in mid-ejection, and there's prolonged acceleration time and ejection time. And when we look at the acceleration time, that's the time here, really the upslope, I would say, or downslope, whichever way you want to think about it, to the peak. And so a short acceleration time is really less than 80, less than 100. And in the presence of obstruction, it would be more than 100 milliseconds. And the way you calculate your acceleration time, it's the onset to the peak velocity measurement divided by time. We can also look at the acceleration time to ejection time ratio. And the ejection time is, as we can see in the image here, the entire time versus the acceleration time. And if we look at the ratio and it's more than 0.4, that's also indicative or suggestive of obstruction. So the next parameter to look at is the EOA, or effective orifice area of the valve. And the EOA of a prosthetic valve by continuity equation is better than the index of the valve function, is a better index of the valve function than the gradient alone. And it's important to keep in mind that the EOA is not equivalent to the prosthetic valve size directly. So when we look at the calculation of EOA, so it really is the stroke volume over the VTI of the prosthetic valve. And the stroke volume is derived from the adjacent site cross-sectional area multiplied by the VTI. So in the case of an aortic valve, it would be the LVOT diameter, calculating the cross-sectional area there, multiplied by the VTI of the LVOT. And then you divide that by the VTI of the prosthetic valve, which is the velocity time interval through the prosthesis determined by a CW Doppler. And in the prosthetic aortic valves, a normal EOA would be more than 1.2 centimeters squared. And if it's less than 0.8, then that's suggestive of obstruction or significant stenosis. Just to keep in mind, when measuring the LVOT diameter, there are some differences in the measurement for mechanical and bioprosthetic valves versus percutaneous valves. So it's recommended for mechanical and bioprosthetic valves that you should measure immediately below the prosthetic valve from the junction of the septum and sewing ring to the sewing ring in the anterior mitral leaflet base. Whereas for TAVI, it's recommended that you measure at the inferior aspect of the TAVI valve, measuring the outer-to-outer dimension, as we can see here on the right. So we chatted about EOA. I just want to move on now to chat about the Doppler velocity index. So the Doppler velocity index would be calculated by the velocity of the LVOT over the velocity of the aortic valve. And the way that we measure this is by taking the max LVOT velocity in PW. So you just back away enough from the valve to avoid turbulence from the valve. And then you can calculate the max aortic valve velocity in CW, and you want to obtain the highest velocity from whichever view you can get it, whether it be the apical 5, substernal, right parasternal, whichever view gives you the highest velocity. And a DVI that is less than 0.25 would be highly suggestive of significant stenosis. And the value of the Doppler velocity index is that it really avoids the need to measure the stroke volume and is not influenced as much as by the LVOT diameter. So just to summarize some of the key findings on Doppler assessment of prosthetic aortic valves, so we chatted about the peak velocities, significant stenosis being more than 4, mean gradients more than 35 would be significant, and EOA less than 0.8. We talked about the Doppler velocity index less than 0.25, suggesting significant stenosis, acceleration time more than 100, and then looking at the jet contour. And if it's rounded and symmetrical, then that's typically abnormal. And in any of these cases, if prosthetic aortic valve stenosis is suspected, then transthoracic echo is usually not adequate for visualization of the leaflet motion or the presence of thrombus. So in those cases, we normally require fluoroscopy of the valve or further assessment with TEE. So that's the assessment of aortic prosthetic valves for stenosis. So the assessment of prosthetic mitral valves is similar. However, the values are a little bit different. And the parameters that we look at are just slightly different in ways, in that we also look at the pressure half time, which we don't really look at so much for the aortic valves. So in terms of the Doppler assessment of mitral valves, this is again just an excerpt of the normal values from the 2009 guidelines on echo assessment. And when we look at normal and abnormal peak velocities, the values are different. So normal would be less than 1.9 meters per second, and a mean gradient less than or equal to 5, and then abnormal is considered if it's greater than or equal to 2 meters per second for a peak velocity and a mean gradient more than 10. When we look at the EOA by continuity, so it's a similar idea as what it was for the aortic valve. In this case, though, you're taking the cross-sectional area of the LVOT and the VTI of the LVOT, and it's divided now over the VTI of the mitral valve. And for prosthetic mitral valve stenosis, it's suggestive if the EOA is less than 1 centimeter squared. And it's important to note that it's not appropriate to use the pressure half-time formula, the formula of 220 over pressure half-time, to estimate for EOA for the prosthetic valves. And the next is our Doppler velocity index. So again, it would be the VTI of the prosthetic mitral valve over that of the LVOT, and a value of more than 2.5 would suggest stenosis in this setting. So this is similarly just a summary of the guidelines for what would be considered significant or possible stenosis in prosthetic mitral valves. And the pressure half-time measurements, normal would be less than 130 milliseconds, and significant stenosis is suggestive it's more than 200. Okay, So I want to go on to chat about elevated prosthetic valve gradients. So when we're looking at prosthetic valves, it's important to remember that some elevation can be considered normal in prosthetic valves, and that's why we can refer to the guidelines for normal values in the 2009 JACE paper. But high gradients may be seen in normally functioning valves in the setting of increased stroke volume, small size with pressure recovery, patient prosthetic mismatch, or if there's improper measurement of velocity. But other causes of high mean gradients or max velocities can occur in the presence of valve obstruction, whether it be thrombus, pannus, degeneration, or large vegetations, as well as in the context of significant regurgitation. And even if there's just mildly elevated gradients in the context of severe LV dysfunction, that may still indicate stenosis, and gradients alone are usually not enough to evaluate malfunctioning prosthetic valves, and you also want to get more information. So before we delve into all those ideas, I want to take a quick sidebar and chat just briefly about pressure recovery. So in order for, I guess, just to think about pressure recovery, in order for us to get blood from the ventricle to the rest of the body, the ventricle needs to generate mechanical energy, which then gets converted into kinetic energy in the blood, and that's to help move the blood through the aortic valve into the aorta. And the kinetic energy is normally the highest at the EOA, which is where we typically measure at the vena contracta. As the blood moves past this point into the ascending aorta, some of that energy is lost as thermal energy, and then some is recovered as pressure recovery. Exactly how much is converted to thermal energy versus pressure recovery is typically unclear. But the most important really determinants of that ratio between the EOA and the aorta is the ratio between the EOA and the aorta cross-sectional area. So essentially what I mean by that is the higher the ratio, the more pressure recovery there is. So patients that have a small aorta will have more pressure recovery compared to those that have a larger aorta. And so we can see, if we use this patient as an example, so this is our first patient who has a relatively small aorta. Their peak velocity initially is 170. And then their pressure recovery here will bring them to 145. And then in contrast, if we look at patient 2 here, their initial peak velocity is higher at 185 measurement, and they have less pressure recovery down to 145 afterwards. So the reason why this is sort of important is when we think about measurements of our EOA on echo versus cath, the site of measurement is actually a bit different. And so with echo, we can, in the context of pressure recovery, overestimate the peak gradients. So it's important to think about pressure recovery in the context of patients with a very small aorta. So if they have a sinotubular junction less than 3 centimeters, and the other context where pressure recovery is often can be implicated is in the presence of small bileaflet mechanical valves. So the second thing that I want to chat a little bit about is patient prosthetic mismatch. So patient prosthetic mismatch occurs when the prosthetic valve area, or EOA, is too small for the patient's size. And key things that should make you suspect PPM is elevated gradients post-operatively with a relatively normal appearing valve, normal or mildly low dimensionless index, DVI greater than or equal to 0.25 in the presence of an aortic valve, short acceleration time, or if the indexed EOA is too small. And some of the determinants of mismatch are a larger BSA, so they require higher cardiac output requirements, older age, very small prosthesis size, less than or equal to the size of 19, as in the case that we presented earlier, and if they had the prevalence of valvular stenosis as a predominant lesion prior to the operation. So there's this very nice algorithm that helps us work through the likelihood of patient prosthetic mismatch. So essentially, if patients have an abnormal peak jet velocity, more than 3 meters per second, then you'd want to calculate the DVI. If the DVI is either more than 0.3 or between the range of 0.25 to 0.29, then that leans you to the left half of this algorithm. And at that point, you really want to look at the jet contour and the acceleration time. So there's more of a triangular shape to the jet contour, which would lead away from classic findings of stenosis and an acceleration time less than 100 milliseconds, then that's a normal functioning prosthetic aortic valve. And then after that, you can look at the EOA index. to help differentiate from a high flow state versus patient prosthetic mismatch. And depending on what the EOA is, so if it's more than 0.85, then that's typically considered insignificant. If it's less than or equal to 0.65, then that's indicative of severe BPM. So what are some of the methods that we can use to prevent patient prosthetic mismatch? So the guidelines really say that prior to implanting a valve, you should calculate the patient's VSA, determine what their minimal projected EOA should be, and then you want to choose a prosthesis using the reference values that are set out. And there's a number of different tables that you can use. This is just one example of them based on the patient's BOA and average EOA, and then the prosthetic size of patient. Okay. So we chatted a fair bit about the initial Doppler assessment for stenosis of both aortic and mitral valves. And now I just want to spend a little bit of time chatting about prosthetic valve regurgitation. So regurgitation in prosthetic valves can be both physiological or pathological. When it comes to physiological regurgitation, most mechanical and many prosthetic valves are usually associated with a trivial or mild amount of regurgitation, which is known as physiological regurgitation. And this is typically due to closing volume, which results in retrograde volume displacement as the valve leaflet closes. And this physiological regurgitation usually occurs at the hinges of an occluder. And then with especially our mechanical valves, there can be washing jets, which help to prevent thrombus formation. And if we look at them on echo and Doppler, washing jets typically are low momentum, homogeneous in color, and aliasing is usually confined to, the base of the jet. In contrast to physiological regurgitation, pathological regurgitation can be either central or intravalvular or paravalvular. Intravalvular pathological regurgitation is usually common with bioprosthetic valves, and it's usually technical or infection related. When it gets severe, it's typically a broad-based jet that we see. In context of paravalvular regurgitation, this is usually common with either bioprosthetic or mechanical valves. Typically, there is some mild paravalvular regurgitation that can be common after surgery, occurring in about 5 to 20% of bioprosthetic valve, in prosthetic valve. It's usually not progressive, and it's quite common with TAVIs. Late paravalvular regurgitation should raise a suspicion for possible suture dehiscence, poorly seated rings, or endocarditis leading to valve dehiscence. And in patients who have a high amount of calcium debridement, redo, or older patients, it is more common. And one of the clinical presentations for possible paravalvular regurgitation can be hemolytic anemia. And this is actually even more common in the presence of mitral valve repairs. So this is just an interesting study that looked at the detection rates of regurgitation using transthoracic and transesophageal echoes in 136 mechanical valves. And what I found sort of interesting about this study was that there are much higher rates of detection of regurgitant jets, non-surprisingly, on TEE versus transthoracic echo. And that's often due to sort of shadowing. But what I also found interesting was the higher detection of mitral versus aortic regurgitation on TEE. And this lower incidence of detection in the aortic position on TEE may be explained by some shadowing in the LVOT on transesophageal, but I did think it was interesting that there was lower detection rates for that. So when we talk about assessment of prosthetic valve regurgitation, intravalvular or paravalvular AI can usually be identified on transthoracic echo. And the width of the vena contracta, however, may be difficult to measure, and sometimes we may require more off-axis views to get good measurements. In contrast, prosthetic mitral or tricuspid regurgitation is often quite difficult on transthoracic echoes due to acoustic shadowing or more eccentric jets. So in those cases, TEE is usually preferred. And regardless, it's often quite difficult to quantify the paravalvular leak for TEE. So when it comes to aortic valve regurgitation for prosthetic valves, grading the severity is quite challenging. Obviously, if there is significant dehiscence, lots of rocking motion, usually that's associated with severe regurgitation. Some of the other classic indicators for severe regurgitation are a jet width that's more than 65%, pressure half time less than 200, if there's evidence of hollow diastolic flow reversal in the descending aorta, a large regurgitant volume more than 60 milliliters, or regurgitant fraction more than 50%. There are other criteria that can help differentiate mild versus moderate versus severe, but these were some of the main ones that I had mentioned: the jet width, the density of the CW Doppler, the pressure half time, hollow diastolic flow reversal in the descending aorta, and then the regurgitant volume, the regurgitant fraction. This is just a really interesting and good image that I found from the ASE Echo handbook. And I just thought it was a very nice sort of representation of when you're detecting paravalvular AI with color Doppler, where those may correspond to relative to the valve based on which view you're looking at. So I just thought it was a good representation of if you're looking at the parasternal long axis. If you're seeing a leak here, it's typically anterior versus here would be posterior. On the 5-chamber, you're looking at medial versus lateral, and then the 3-chamber, again, it's anterior and posterior, similar to a parasternal long axis. And then on the short axis, pretty self-explanatory, but anterior, posterior, medial, and lateral. So it's just a good representation. And then it also gave this representation of sort of mild, moderate versus severe, looking at the vena contracta area and the circumference of regurgitation, and then the jet length. So all it's sort of useful findings to help differentiate or classify the severity of aortic valve regurgitation with prosthetic valves. Oh, I just saw some of the messages. Can you guys still hear me?
Yeah, absolutely.
Okay, sorry, I just saw that. I just wanted to make sure. So just to move on to prosthetic mitral valve regurgitation. So in terms of the assessment for prosthetic mitral valve regurgitation, so as I mentioned, it's quite challenging on transthoracic echoes due to the acoustic shadowing. So we can look at other cues on transthoracic echo that might point towards possible regurgitation. So some of the key things that you might want to look for is a lot of rocking associated with sewing ring dehiscence. You can look at the transmitral EUA velocities, and if there's an increase in the peak transmitral EUA velocity, that can be indicative. Increased mean gradient, the pressure half time remains normal, and if the LV volume is increased with preserved EF, that might also be an indication of significant regurgitation. Ultimately, though, if you are thinking or suspect prosthetic mitral valve regurgitation, then really you need to do a TEE for diagnosis. Okay. So just like there was lots of parameters for identifying the severity of aortic, there is also lots of parameters for identifying the severity of mitral valve regurgitation with prosthetic valves. I did sort of mention most of these. So the color flow jet area, the density of the Doppler. You can also look at the shape of the Doppler, whether it's early, peaking, and triangular, that's more consistent with severe. Pulmonary veins to look for systolic flow reversal, and then your quantitative parameters, which would be your vena contracta width, your regurgitant volume, regurgitant fraction, and your EROA. And all of those are useful findings. Okay, so one of the other things that can often go alongside regurgitation with prosthetic valves is the presence of prosthetic valve dehiscence. So this is identified as separation of the prosthetic ring from the native valvular annulus, usually accompanied by paravalvular regurgitation. Most frequently, it's caused by endocarditis, and typically you can get the presence of rocking. So in the aortic position, if you see rocking, that's usually indicative of dehiscence. In the mitral position, they say that rocking could be indicative of either dehiscence or possibly retained native posterior leaflet or retain both posterior and anterior leaflets. So really in those scenarios, you want better visualization with TEE. Okay, so the last thing that I really want to go through is some of the complications associated with prosthetic valves. So there's a wide list of complications that you can really sort of differentiate into early and late. So some of the early complications being obviously paravalvular leak, thrombosis, which is more common in the setting of mechanical valves, low output, and endocarditis, which can really occur at any stage, LVOT obstruction and patient prosthesis mismatch, which we talked about earlier. In the late setting, there can be pannus, thrombosis, and thromboembolism, Over time, you can get valve degeneration, which can lead to either stenosis, regurgitation, or both. You can get hemolytic anemia, especially in the setting of paravalvular leaks, leading PPM again, endocarditis, valve dehiscence, and pseudoaneurysm formation. There's quite a long list of possible complications that can occur. When we talk about structural valve deterioration, this is really most common with tissue valves, more common in younger patients, those who have altered calcium metabolism, and really depends a bit on the valve type. So findings that you can get with structural deterioration are thickening, calcification, perforation, or spontaneous tissue degeneration of leaflets. It can cause, as I mentioned, stenosis or regurgitation, usually gradual, but there is a possibility that this could be more acute and severe. And when we look at the incidence of bioprosthetic valve dysfunction, it normally increases about 10 years post-implantation. And this is just sort of some examples of what this might look like. So we can see on the left evidence of wear and tear, calcification, and then pannus, which we'll chat about in a minute. So when we look at pannus versus thrombus, which are some of the two sort of main things that we think about with obstruction of valves, especially more in the long-term setting, this was an interesting study that was a surgical study that looked at 112 obstructed mechanical valves. And what it showed was that pannus for mechanical valves was sort of the cause in about 11% of cases. There was pannus with thrombus in about 12%, and then thrombus alone in 77%. So it just sort of can help with your sort of pretest probability when you're thinking about the valves. And we can think back to the case that we presented at the start of the talk, and what might also have been indicated in her scenario. So when we look at thrombus versus pannus and how to sort of differentiate them, so thrombus is typically larger, it's less echo dense, similar to myocardium on echo. It tends to be more mobile. You can often see a mass that projects beyond the surgical ring into the left atrium. Thrombus is more common with mitral valves versus aortic, and they tend to have a shorter duration of symptoms. Obviously, it's more common with mechanical valves and patients who have poor anticoagulation. In contrast, if we look at pannus, it tends to be smaller, it's more echo dense, and sometimes might not be visualized. It tends to be more fixed. When we look at it, it tends to grow in from the suture line along the plane of the valve and can extend into the prosthesis. Usually more common with aortic versus mitral, and the duration of symptoms tends to be longer. And at the bottom here, we can see some examples of what pannus looks like on gross inspection, as well as on echo here. And this is on its EEE. Thrombus in comparison. So this is an example. The image on the left is, so this is a prosthetic St. Jude mechanical mitral valve with valve thrombus here. In the first image, the arrow points to an obstructing thrombus, which is immobilizing one of the leaflets of the valve. And associated with this, there's an elevated mean gradient of 12. We said that previously significant stenosis for mechanical mitral valves would be, or prosthetic mitral valves would be more than 10. So this is obviously significant stenosis looking at the mean gradient. And then on the right here, we see an image which is post-thrombolysis. And we can see here that the leaflet mobility looks like it's restored. We no longer see that thrombus there, and the mean gradient is now significantly decreased post-thrombolysis. So when we do suspect possible prosthetic valve thrombosis, there is sort of this nice guideline on sort of the step-by-step process in terms of how to evaluate. So for anyone who you suspect valve thrombosis, you should do a TEE as a first step to evaluate the hemodynamic severity of it. And there's a class 2A indication that you could consider CT or fluoroscopy at that time to evaluate the valve motion. And then they really differentiate into left-sided versus right-sided valve thrombosis. If it's left-sided, you should look at the thrombus size, and then depending on the size or the clinical symptoms, so if they're NYHA class 3 or 4, then that's either a class 1 or class 2 indication for surgery. Otherwise, if it's more recent onset, smaller in size, or they're less symptomatic, you consider fibrolytic therapy after IV heparin, if it's persistent after heparin therapy. And then the same sort of approach is taken for right-sided prosthetic valve thrombosis. So then the last thing to chat about is sort of monitoring of prosthetic heart valves. So the 2014 guidelines, and there's also 2020 guidelines that looks a little bit at percutaneous valves, but generally the monitoring guidelines recommend that an initial transthoracic echo should be completed after implantation within 6 weeks to 3 months. And then a repeat echo should be performed if there's a change in symptoms or signs suggesting prosthetic valve dysfunction. In terms of class 2 recommendations, you could consider, or would be reasonable to consider, annual echoes in patients with bioprosthetic valves after 10 years, even in the absence of change in clinical status. And I guess the thought is behind that is that that's the sort of time period when the valves start to degenerate more. So I wanted to now go back to our case that we had before, because there was quite a lot going on with that case that we first looked at. So that was our 25-year-old female, and if we recall, she had a mechanical mitral valve, which was a St. Jude 27, and a mechanical aortic valve, which is a St. Jude 19, which had been implanted 3 years prior, and her initial echo had shown that her aortic valve gradients were significantly high. She had a mean gradient of 68 and a stroke volume of 39. I think her Vmax was 5 over 5. Her EOA was low at 0.3. There had been mild intravalvular regurgitation and no paravalvular regurgitation. So we think sort of some of the etiologies for her elevated gradient, certainly if we think back to sort of determinants or risk factors for patient prosthetic mismatch, having a very small valve initially, so a size 19 or less valve, it was probably too small for her BSA, and she actually, I didn't put her BSA in the initial case presentation, but it actually did measure out to be too small if you look at the charts. And then other findings were actually when she went to surgery, she did have significant pannus restricting the leaflets, as well as what appeared to be old matured thrombus between the struts of both the mechanical leaflets. And that's not surprising given the fact that she was suboptimally anticoagulated. So she actually went to the OR for a redo aortic valve replacement, and she had a mechanical AVR with a St. Jude 21 now put in. And post-procedure, her gradients were much better on her repeat echo. Her mechanical aortic valve gradients had gone down to 6, so the stroke volume of 41, or EOA with 1.8. There was no regurgitation, and her mechanical mitral valve gradients had gone down to 4 at a heart rate of 91. So all was significantly improved. So I just wanted to finish off with one last case, and given sort of everything that we went through earlier, I don't know if one of the cardiology residents might want to go through this one, but this is a 77-year-old male who had a history of mechanical aortic valve replacement 23 years prior, had hypertension, lots of cardiac risk factors, dyslipidemia, type 2 diabetes, BPH, and a known aortic aneurysm ascending, involving the aortic root and the ascending aorta. And he actually was asymptomatic, surprisingly, at the time of his presentation, and this was just a follow-up echocardiogram that was done. So I don't know if anyone wants to take on this echo. It's a shorter one. Are there any cardio residents on?
I can do my best.
Go for it, Jonah.
Okay, so this is the parasternal long view. There looks like there's a very dilated ascending aorta and a mechanical aortic valve.
Sorry, it's skipping.
It's okay. The mitral valve leaflets open well, and the LV looks a little enlarged, but otherwise it's okay. Looks like maybe there's some AI. That's what I see in that view.
Okay. And just as what we can see here, we look at the sort of width of this, it's taking up majority of the LVOT here. There's lots of turbulence there as well.
Yep. It's probably eccentric. We'll probably get better views of it. We can see the mechanical valve opening and closing. It looks like maybe the leaflets are restricted a little. Here we're in a parasternal short of the aortic valve, and again we can see the aortic valve leaflets. They look again, I can't really tell if they're opening well, or they seem like maybe they're not opening well. Here you can see I think better the AI, and it looks, yeah, severe and turbulent.
Okay.
This is like a off-axis 4-chamber.
Sorry, it's a short.
It's a short. Sorry. Okay, so it looks like maybe there's some RV pressure overload. It looks like the septum's a little flat in systole.
It's a little off axis, so we won't focus on this one too
Okay.
much. There's a better view.
Okay, yeah. All right, yeah, I mean, I think these are okay. The chamber just looks a little enlarged to me. Yeah, the LV seems a little large.
Mhm.
Or maybe more than a little. Some mild MR. Yeah.
It's a bit of a weird view. It's a
bit of a
5-chamber
five
here.
chamber, yeah, but there's
Yeah,
just
the
a lot of
aorta is just really
shadowing
dilated.
and mechanical valve.
Mhm.
And yeah, here we have a better view of the severity of the AI. It looks like there's multiple jets. And that's my impression, is there's multiple jets and a lot of turbulent flow. And you can't really see beyond the valve because of the shadowing.
Mhm.
Here we have our CW of the regurgitation. We can do pressure halftime to try and grade that. Okay, this is our LVO TV max. It looks okay, I think.
5 and 7.
Okay, so it looks like there's significant so I guess this you were saying this is kind of in the intermediate zone, because you were saying above 4 is definitive abnormal and less than 3 is definitively or more normal. So that's kind of like 3 to 4 meters per second.
Yeah, for stenosis.
For stenosis, yeah, but
But
probably
we're thinking
abnormal.
more about regurgitation right now.
Yeah. But also
But
maybe some
certainly
stenosis.
elevated gradients.
Yeah, yeah.
Okay. And then the last thing, which tells us a little bit more. This
Okay,
is your
this is
descending
the
aorta.
descending aorta, right? This is
Yeah.
this is a suprasternal view. Yeah, so
Yep.
what we're seeing here is diastolic flow reversal in the descending aorta, which again is suggestive of severe AI.
Perfect. So good job, Jonah, going through. Thanks for talking about that case. So yeah, you went through most of the findings there. So this patient had a dilated LV. I didn't show you all the images, but they had relatively preserved LV systolic function. Their mechanical aortic valve had quite turbulent transvalvular flow, and the peak mean gradients were 56 and 37 with the EOA of 1.2. And they had quite severe intravalvular AI, which we could see by all the criteria that we went through earlier, as well as the holodiastolic flow reversal at the end there. And sort of when you think about this, you think about what your differential might be for the cause of this, whether it's valve degeneration, if there's thrombus or pannus or other etiologies. And the other thing that we didn't see here is this patient also had a severely dilated aorta. I didn't show you the images, and a mildly dilated aortic root that measured 5 and 6.5 respectively. So that was just sort of another case. This patient did not go to surgery, but due to their own personal requests. But that was just sort of another case of some of the complications that we can get with prosthetic valve. So I'll end it there, and if anyone has any questions, I'm happy to answer them.
So thank you, Taylor, for this very, very comprehensive review. I think you covered like many, many different aspects of issues related to prosthetic valve. Just an interesting historical point about patient mismatch. This is a concept that was actually very Canadian. It's brought to us by Dr. Philippe Pibereau and many, many years ago, and in Laval. So it's a very, very Canadian thing. So just something that we are all proud of. And Dr. Jean Demineux as well. So both of them in Laval. Any questions, comments?
My only comment, it's a great talk, Taylor. Thank you.
Thanks.
Taylor, that was great. Can you talk, you mentioned a bit in your talk, can you expand a bit briefly on some of the challenges that we have in quantification, or at least the assessment of severity of aortic regurgitation after TAVI. You know, the paravalvular leak that occurs, it's quite challenging to assess it. And then kind of related to that, any thoughts on other imaging modalities to aid in assessment when transthoracic and T doesn't seem to work?
Yeah, so I talked a little bit about it earlier. So I think there's sort of a number of different factors when you're looking at the paravalvular regurgitation. One is obviously trying to make sure that you get the best Doppler view of it. And that can sort of be limited a little bit by the angulation of our probe and trying to get some off-axis views occasionally to get a clear shot through it, depending on sort of anatomical variations between different patients. And then sort of if there's any evidence of shadowing or sort of acoustic shadowing from the valves, especially with mechanical valves, that can sort of limit things as well. And even like I mentioned that one study there that even looked on esophageal echocardiograms, even I think in that setting, the detection rate was only about 40s to 50%. So we want to sort of think about other ways in which we could improve the detection. I think there is sort of some other imaging modalities that we can look at. I'm not too familiar in terms of how useful they are. So if anybody else on the line is more familiar, I think there is some evidence for using CT. And we can also look at fluoroscopy. To also look at them, but I'm not sure, potentially MRI, although I think that may be limited as well.
Yeah, no, I think MRI certainly is a useful tool, especially for regurgitation. You know, T is better than transthoracic, but even with transesophageal, some of my echo colleagues can talk this as well. You know, the whole circumferential extent is difficult, and then I'm not sure about the vena contracta area. That's going to be challenging. But you know, when it's clearly severe, it's pretty easy. Anything less than that, it becomes challenging. Kim, you had any comments?
No, I was just going to echo what everyone said in the chat. Great rounds, Taylor. The only thing I was sort of going to emphasize was it's really important that we try to identify the make and model and number of the valve. I know you mentioned, Taylor, one of the most important things was comparing to the previous one, but not infrequently we've had cases where people have sort of turned up in the TE lab and we don't have that information. And although sometimes you think it might be easy to identify if it's a bi-leaflet or a single leaflet valve, sometimes it can be harder, particularly when persons have come from overseas. And, you know, we have a number of patients who come from India and so on, that valves are many, many years old. And without having that, we can't then exactly, as Taylor has put up, relate it to this particular data so that we know what are the expected ranges for the valve. And that is also important to help you determine what the likelihood of pannus versus thrombus is. So I think, you know, a bit like before you do your angiogram, someone's had bypass, you really want to know what the graphs were. It's the same sort of concept here. And if in doubt, I often find it's easier to screen first with fluoroscopy and then do the TEE actually, which sometimes sounds a little bit backwards, but often that makes it much clearer there. And because often with the acoustic shadowing and so on, it's not as easy as you think there. So I think, you know, it's really important wherever we can that we identify to the best extent exactly what sort of valve was implanted, and then that will really guide the right procedures moving forward to help you identify what's truly abnormal or not, because that gets back to that algorithm about what's PPM and then what's potentially pathologic, as in thrombus or pannus, because obviously they're very, very different management depending on what your ultimate diagnosis is.
I kind of agree more with what Kim just said. It's very important when you're making a referral to an echo lab to write down the model, the size, and also the date of implantation if possible. It will help us tremendously.